Okay, good afternoon again, everyone. Just to let you know, I am recording this meeting, so I've already started the recording. Thanks, everyone, for being with us this afternoon over your lunch hour. Hopefully you were either already able to grab lunch or brought it with you. This is a pretty informal meeting. Just want to give some background about why we're having these. So as part of the South Dakota Colorectal Cancer Control Program work plan, we included a learning collaborative in our activities. So it's really an opportunity for the health systems that we're working with through the grant to come together and to learn about a variety of topics on colorectal cancer. We have a planning committee, one person from each of the health systems that works with Department of Health and myself to determine which sessions we'll be offering. And so that's kind of the background behind this. We will offer the sessions quarterly. And so our next one will be in August. And I just realized I forgot to introduce myself because I don't know that I've met everyone that's on the meeting today. So I'm Brooke Lusk, and I'm a nurse consultant for the South Dakota Colorectal Cancer Control Program. We did just get some exciting news yesterday, so I'm going to touch on that a couple times during the presentation, but the U.S. Preventive Services Task Force made their final recommendation to decrease the screening age recommendation to age 45. So that's going to bring about some pretty significant changes for all the health systems that are working to screen patients. Because of that, there should be some upcoming webinar opportunities to hear from national experts on this topic, and then likely we'll have that be our focus at our August learning collaborative. So just keep that in mind. I will share any upcoming webinars that become available or any new resources that become available because of the changes that just happened. So just wanted to mention that. I did want to introduce the other two presenters today. So at Falls Community Health in Sioux Falls, we have Sarah Romeo, and Sarah is a nurse navigator at Falls Community Health. And then she's also a nurse at Avera McKinnon Hospital. That's her waving there. And then Dr. Tingley is also at Falls Community Health. Dr. Tingley is the Chief Medical Officer for Falls. And so we'll be hearing from both of them, and I will also be presenting some information. Again, this is informal. We have some slides to present, some resources to show on this topic, but really just a great opportunity for all of you to ask questions or even share resources that you've developed to help you around this topic of determining which screening tests are the best for your individual patients. So our first slide, I'm going to run the slideshow. So Sarah and Dr. Tingley, you just let me know when you want me to advance. So I'm going to advance to the first slide for Sarah to discuss. Maybe. There we go. Sarah, I think you're on mute. There you go.
Okay, so like Brooke said, I'm Sarah. I'm the colon cancer navigator here at Falls Community Health, and obviously my main goal is to try to get the patients screened in different ways. And this was one new thing that we started to utilize to send out to our 49-year-olds, so they ultimately would be screened by the age of 50. So this is our roadmap in a sense, the start and the finish, and it kind of just goes throughout hitting on some positive notes of things you can do to hopefully maintain a healthy diet, to maintain a healthy colon, but also things that you can do to prevent colon cancer. Regular exercise, maintain a healthy weight, limit the red and processed meats, and so forth. And then throughout it also hits on points that allow you to look at ways that when you should be screening. Ultimately, we want everyone screened by the age of 50, and I know there are new guidelines, but right now we're at 50. And sometimes, though, people need to be screened earlier than that. So that's why we start sending this out at 49 to help them kind of get in the idea that, okay, I need to be screened by 50, but, oh, currently, as you can see in that first bullet, a family history of colon cancer. Well, I should be screened now. Or inflammation, as Crohn's or colitis, I should be getting screened now. So it kind of helps to hit on a few different points. But I really like the visual of this. Obviously, it shows a colon, which is great for people to have knowledge of your colon and what it looks like and kind of what part of the body. And then just, things that you can do in your daily life to keep you healthy. So let's see what else. Kind of have a little bit of information in the middle. Colorectal cancer is cancer of the colon rectum, so just some definition and give them more information. But yeah, we like to send this out to our 49-year-olds, and then we also have this in all of our rooms so people can see it at any age to get more information. So
great, thanks, Sarah. And this is embedded in the slides that I sent out, but I am going to follow up with an email after today's training and update a link that wasn't working in the slides that I sent you, and then I can actually attach the PDF of this so that you guys can use it if you perhaps want to reproduce something like this. So next I want to go over a couple of algorithms that are available from the National Colorectal Cancer Roundtable. I am going to show the algorithm for age 50. So the link that you'll get in the updated slides will take you to this page. You'll see that there is a resource to download at age 50 and one to download at age 45. Just for the purposes of the fact that we planned on doing this and then the changes happen, I'm going to pull up the resource for age 50. Just know that the only real change between the two documents is that age, and I'll point out where that is. But again, the new link will take you here. You can download these resources and print them. And these might be something for you to use like in a staff meeting with your nurses or your medical staff to just review the guidelines. I think it's always a good opportunity to review how we assess our patients in terms of those that may have an increased risk based on their own personal history or family history. And we are always talking about screening, but sometimes we forget to think about the fact that, there are those who are at increased risk. And so not all the test options are available to those patients because of that increased risk. So this algorithm helps lay that out, and will also show some documents like Falls is using for screening patients at the end that you may have something similar. Some of your EMRs may also have these questions in them already, but again, just some resources to consider. So when assessing risk, first of all, if you have an average risk person who has no personal history, no family history, these are the guidelines. And again, that other resource just changes this age to 45 because American Cancer Society had started recommending screening at age 45 a couple of years ago. So that's why that document is already available for age 45. So you can see if at this, when we're talking about screening at 50, if they're younger than 50, older than, this should say 75, that's an error. You should not screen them, or you should base it on a discussion between the provider and the patient. But 50 to 75-year-olds should be screened and can select from the test options that are below. Again, remember that these are average risk patients. The other nice thing about this algorithm is it does explain the screening options right here in the middle, and it does include different CPT codes and diagnosis codes for your reference. So it's a real comprehensive tool. So again, average risk patients can choose any of those options, whether it's a FIT test, FIT DNA, which is Cologuard, colonoscopy, sigmoidoscopy, CT colonography, and then of course, the screening increments that are associated with each of those tests. But for those that are at increased risk, the options are not the same. So for those that are at increased or high risk based on their personal history, so personal history of colorectal cancer, polyps, ulcerative colitis, a long-term history of IBD, when you're doing the assessment, if you do note that for that patient, then these are patients that really should be screened with surveillance colonoscopy at regular intervals as recommended by their provider. So for these patients, those stool-based tests that are so nice to offer to patients who are a little leery about the colonoscopy, they're also a more inexpensive test, are not an option for these patients that are at increased or high risk. And then we have increased or high risk based on family history. So these are patients that have certain hereditary syndromes like familial adenomatous polyposis, other polyposis syndromes, Lynch syndrome, those types of family history, or a family member who's been diagnosed with colorectal cancer, again, are not, should not be screened using a stool-based test. These are a little more complicated because if you do have a family member that's been diagnosed, like a first-degree relative, less than 60, you need to look at when you start screening. So that again is a conversation with the provider, but just know if they do have those family members that have been diagnosed, and especially if they've been diagnosed at an earlier age, you should begin screening at an earlier age. So, the recommendation that we've been following to screen at age 50, as Sarah alluded when she was talking about their document, you always have to make sure that you're assessing the risk of that individual patient because you may need to start screening earlier. So again, just wanted to share this resource with you. I think it is a very easy tool to have, up in your clinic, to share with your nurses, to share with your providers. And again, probably something that you could go over during a staff meeting. So you will have the resources to look at that. And now I'm going to go to the next slide and turn it over to Dr. Tingley, if I can get this to work. There we go.
All right, thank you. So I'm going to just give a little bit of background on the community health center world at large, I guess, or at least as large as South Dakota. I know that this is a collaborative with other community health centers, so we probably are all aware, but I think there are some private clinics as well, right? Sanford and Avera. Community health centers are located across the entire country, and the number of patients being seen at community health centers has been rapidly increasing over the last 40 to 50 years. And so this is just a visual of where we have community health centers located in our state. There's a very large system called Horizon Healthcare, and they have multiple clinics located throughout the state. Falls Community Health is, like I said, just one of many of these CHCs, and there's a similar graphic for North Dakota as well. There are also CHCs located everywhere there too. So community health centers, for those that don't know, we receive the bulk of our funding from the federal government. And so with that, there are a lot of reporting requirements, focused on doing quality work, and one of our quality metrics is CRC screening. And so that's why we're very lucky to have Sarah here in our clinic to kind of continue to move that needle in terms of how many patients that we are screening when they're supposed to be screened. So you can go to the next one. Yeah. So that slide there talks about a sliding fee scale. So this would be similar at any community health center across the country. We get money from the federal government, and in return, what we do is offer services to patients that may not have the ability to pay for that. If they don't have insurance, a community health center is a great place for them to receive their health care, because we base our fee structure on their family size and annual income. So this is a table that it changes every year because the federal poverty guidelines also change, and that comes out from the national resources, and then it filters down. So we just use this income guideline based on what the federal poverty guideline is. And then we look at our family size. And so this is how we determine here at our clinic how much a patient is going to pay for their visits. And while this isn't particularly related just to CRC screening, this is just an example of one of the ways that patients can get not just colon cancer screening done, but all of their healthcare done. And that's what community health centers strive to do, is to provide a medical home for all primary care and all preventative healthcare. So, and I will just comment on, and I guess the next slide, probably, you can go to the next slide, Brooke, because this is who we serve here at Falls Community Health. We're a little bit unique from other community health centers across the state in that we have a very large percentage of uninsured patients. So around 50% of our patients do not have any payer source. And then Medicaid is our top payer, so 27% of our patients, and this would have been our 2020 data. So this is who we saw last year. And these numbers really don't change much. We started to see our uninsured rate drop a little bit in 2017 and 18 with the Affordable Care Act increasing, but it went back up. And so we'll see. It would be really nice for our clinic to have less uninsured patients and more patients with Medicaid or private insurance. But different than many other states around us, we don't have Medicaid for all. Our state just hasn't gotten there yet. But obviously it would be great if we could move in that direction, because as a provider, it's a lot easier for patients to have insurance than not. And one of the things that I'll point out with this, not having that many insured patients is, Brooke, you talked about if they've had a history of a colonoscopy in the last 10 years, we are not supposed to use things like an FOBT kit or Cologuard. We are supposed to continue with colonoscopies. It's a really hard discussion to have with a patient who lost their insurance last year and they can't afford that colonoscopy, even though we know that that's what they're supposed to have. As a provider, it's like a gut punch. I don't know what I'm supposed to do, because you want them to have some sort of screening. But that's where, we just try and find other resources and other places to reach out to that we can get patients the colonoscopy that they need. So you can go to the next slide. This is, again, looking at our 2020 patient population. This is who we serve. Our clinic is also unique in that we don't serve that many kids. And the one thing that I'll point out, it looks like 23% of the patients we saw last year were 18 and under. The majority of those patients are actually our dental patients. We serve a lot of elementary school children for their dental care. So I would say on the medical clinic side, I consider us more of an internal medicine clinic. We just see way more adults than we do kiddos. We have slowly been seeing our 65 plus population go up. That's just populations getting older. But as a general rule, we kind of see those middle-aged patients here at our clinic. 52% of our patients were female and 48% were male, which is pretty good. Yeah. Yeah, you can flip. In terms of race ethnicity of our patients, the majority of our patients are white, 58%. Black is our second highest race that we would see here in our clinic. These numbers have been actually shifting down a little bit. Our clinic historically has seen a lot of new refugees. We are the site for Lutheran Social Services would bring in Sioux Falls as a resettlement site. And so when they are resettling refugees, those patients will come to Falls Community Health initially for their healthcare. They'll come for their initial refugee lab work, hearing assessment, vision assessments, and then we do their new refugee physicals. The majority of those patients end up staying with us. But over the last few years, there's just been a very, very sharp decline in the number of refugees being brought into the US in general. And so we're starting to see some shifting in our race ethnicity here. So a higher percentage of white patients and less percentage of Asian and Black patients, which historically had been a little bit higher. We used to see a very high percentage of Nepali patients. It used to actually be our top language, and now it's not even in our top 3. So just some shifting around that's been happening with our patient population. So Oh, Nepali is there, sorry. It used to be one, it was one for a long, long time. Kunama is now number one. Somali and Swahili were also top languages for us. It used to, like 23% of our patients used to require a language other than English, but last year was just 14% of all of our patients required an interpreter. And the number of languages has also been dropping too. So Nepali is still there. I thought it had dropped, but it's number 2. We also have homeless grants here at our clinic. So patients that they're actually not on that blue, it had that sliding fee with all of those numbers. If a patient's identified as homeless, which could be both living on a shelter, in a shelter or on the street, but also just transitional, that would be the highest percentage of our homeless population. So kind of couch surfing or jumping from house to house, even living in a hotel, that would be considered a transitional. In addition would be patients that are doing chemical dependency treatment, outpatient treatment, that would be considered transitional housing. So last year we saw 777 patients identified as being homeless. And when a patient is identified as part of our homeless grant, they actually do not pay any copay to come into our clinic. So it's free for them to receive their services here. And again, the federal government will pay for those services. And quite honestly, the city of Sioux Falls is very, very supportive of us. And I think they pay over $1 million every year to keep our clinic operating, which is wonderful that they do that. But again, if we had more insured patients, that would drop, which would be good.
Dr. Tingley, thank you for that background of your patient population. I need to pull up another slide to show. And so while I'm doing that, I'm wondering if you might talk about the test that you use most frequently for your patients based on that patient population and those demographics that you just provided.
Yeah, yep. So the test that we use pretty much universally here is the IFOBT kit. And so that is an annual test that we provide here. And it is one of those things that there are some additional resources that we have that's just the test of choice, I would say. We have some patients that have insurance that prefers more of the Cologuard. And so that's very few, very, very few people I think would leave here with a Cologuard test. A lot of times that's actually just sent to them by their insurance company. But if we are giving out test kits here from our clinic, we're using the IFOBT kit.
Thank you. Now I'm going to pull up the slide that goes over the other tests, if you wouldn't mind just speaking to those different tests.
Yep. So again, I think the adage always has been the best test is any test that someone is willing to use. Now again, those caveats of having those patients with genetic disorders or a history of having a colonoscopy, and if they've had polyps or something abnormal on that colonoscopy, those are the ones that you really do need to stick to that colonoscopy. But if you have just that average risk patient and they don't want to jump into that quote unquote gold standard colonoscopy, this is where these other tests are very, very useful. And I find that patients are much more likely to accept taking a kit home than they would be to agree to do a colonoscopy. So the ones listed here, the first one is the FIT or the IFOBT. And again, the IFOBT is what we offer here. This is just a little take home thing. You know, I always tell patients, I just use words that are similar to what a 3-year-old would use, but you know, it's like sticking a little pin inside your poop, and we send that, we show them how to do it in the clinic. The nurse will go through that and kind of, if they've never done it before, actually show them how they're going to do it. This one's really nice because you just close up the cap, you put the cap on it, throw it in the envelope, and put it in the mail. I mean, patients are just baffled that that's how easy it is. You know, you just kind of have to get them over the fact that they do have to handle their feces just for a short period of time. But once you get them past it, I find that they're fine, right? It's not that big of a deal. And especially if you've had kids, I'm like, oh, that's nothing, it's fine. But that one is checking for the presence of blood. That's what the FOBT kits are looking for. So it's an immunochemical test looking for the presence of blood. The one thing that, you know, I think there is this distinction between the FIT and the IFOBT. Again, they're both annual tests. So in terms of just how frequently you would use them, I think, you know, that's the same. But some resources will say that the IFOBT kit is better at looking at bleeding kind of throughout the entire GI tract, whereas the FIT, just the FIT test, is better at kind of finding that lower GI tract. Again, any kit is better than no kit, and I think you wouldn't, you know, oh, if I can't get the IFOBT, should I not do it? The answer is no. You know, if your clinic has a resource to do FIT testing, then do that. We just are lucky to have the availability of the IFOBT kits, so that's what we choose here. The Cologuard, like I said, that one we don't see very often around here, but that is the only FDA approved for DNA testing. So it has both the immunochemical testing along with looking for altered DNA in the stool. So this one's a little bit different in that it's every 3 years, so that's kind of nice. But we just, I mean, we would never recommend this for one of our uninsured patients. The cost would probably just be higher than it needed to be, especially knowing that we have the IFOBT as a resource here. So that's Cologuard. And then we get into the actual direct visualization tests in the colonoscopy. Again, I call that the gold standard, but that it's really, I mean, obviously you're looking in the colon, you get to see what's going on in there, but that's not necessarily the best test for everybody. If they're willing to take a kit home, do that. But the colonoscopy, you know, you have to go to the hospital, you have to do the prep ahead of time, you have to have a driver. And for us, our patients, that's often a barrier is how do I have somebody come home with me afterwards? Who's going to stay with me? Those are some challenges that we've had with some of our patients. But obviously a very, very good test. And then if everything looks good in the colonoscopy, that buys people 10 years in between screening. So if there are polyps or there's something abnormal seen on that colonoscopy, they may recommend doing that again in 3 years or 5 years. If the prep is bad, they may say, let's do another one in 1 year. So it depends on how that pathology comes back, if they take any biopsies, but again, colonoscopy is a great option. Flex SIGs, I just don't see a lot of people doing those anymore. They're every 5 years, so again, buys you a little bit more time than a kit that you take home. But I don't, have you guys seen anybody doing flex SIGs? I don't know anybody. It's kind of like if you're gonna put somebody under anesthesia, might as well just do the full colonoscopy. I wonder if there's just that justification. And then a CT colonography, and again, not something that I've really seen. I don't know if I've seen any of my patients with that, but that is not getting direct visualization. It's looking CT scan, x-rays. You look at the colon, but again, going in and taking biopsies, that's not going to happen in the CT colonography. So we just don't see a lot of that either. So I would say the top 3 are the ones that, you know, we would see the most often here.
Thank you, Dr. Tingley. One thing I would say about Falls Community Health, we've been working with this clinic for a number of years through the colorectal cancer control program. And Dr. Tingley touched on this, and that is the nurse in the exam room demonstrating the use of the IFOBT. Now, we've looked at some data that Falls has collected over the years, and they do have a high FIT return or IFOB return rate, which I think can be attributed to that time that the nurse takes to demonstrate use of the kit so that the patient can ask questions when they're in the clinic and feel comfortable completing it when they're in the home. So just something, you know, that I thought I would share with you based on the data that they have collected over the years.
And the other thing too, Brooke, I mean, we are very lucky to have Sarah. So when kits go out, there are often some friendly reminders that are sent to patients or phone calls that are made to say, hey, we know that you took a kit home. We haven't seen it returned yet. And so that kind of one-on-one follow-up with patients, I think has also led to a lot of success with our return rate. But I do think you're right. I think actually showing patients how to do it makes it seem less intimidating. And you don't want them to open up that kit when they get home and not have any idea what they're doing, because then they won't return it. It's just not going to happen. So it's good to just take that extra minute or two to have the nurse go through it with them. But then to have Sarah's work to follow up is really important as well.
Definitely.
So,
Thank you for that information. Sarah, I think you're going to cover this form next.
Yeah, this is our CRC screening form that we use with each patient. This has been revamped many times throughout the years because we've just kind of seen changes in things such as the 10 years and the age, but we're sticking with the 50 to 75 at this time, and of course can be adjusted. But the goal is just to start from the top and go down to the bottom, and you kind of hit some roadblocks that make you stop and see what's the best screening for the patient. So as I put at top, please complete form only for colorectal cancer screening. Now this is put in place pretty much just for coding purposes. If the provider is requesting to test a positive occult blood in the stool, let's say if the patient has said, I've been having bleeding, we would not recommend this CRC screening form. We would just say to utilize the blood card in the room. Yep. So it helps with coding as well as my tracking purposes. Of course, we want every patient to be screened if they're having blood in their stool, but this would not be what we use. But that is why I put that up top. Patient information is listed, and then we just start with the screening questions. Any family history, yes or no? Have you been screened for colorectal cancer? Now, this is kind of a tricky one, as Dr. Tingley spoke about the 10 years and plus. So what we've decided is that if we can get their ROI or where they receive their colonoscopy from, then they do not have to complete the IFOBT. But if they say, oh, it's been 20 plus years, then we can encourage the IFOBT kit or the FIT. We ultimately try to get that colonoscopy report, and so we can place that in their chart, but then we can also screen them appropriately. Now, we've had some patients refuse. They've had a colonoscopy a couple of years ago and they do not want to have anything done. Well, the best test is the one that gets done. So then we would offer the kit if they are ultimately refusing to do that colonoscopy. We don't recommend that at all. I do try to work with those patients. And the biggest thing is probably the barrier with the financial for that colonoscopy. So we are working with some resources for that. But we start with that, have they been screened, just to get some information, get that report if we can, and if they're a no, then we just keep going on. So 3 and 4 and 5 are kind of our symptom collectors. If they have any of those, answer yes to any of them. As you can see, it says, if yes to any of the above questions other than number 2, colonoscopy is the preferred method of testing, and we do not want our staff to give that IFOBT kit. If the patient is currently bleeding, it's just going to be a false positive, and we already know that there's blood in the stool, so we need to have a colonoscopy done.
Something's going on.
Yeah.
Somebody's got to take a look.
Yep. So we just use this form as the best screening form for our patients to see what we need to give them, if it's the kit, or refer them for a colonoscopy. And our nurses do a great job with that, of collecting those ROIs, that information from those other organizations, or referring them off. This is also, as a navigator, my ticket for each patient. So if I receive this, then this is my reminder to have them return the kit. And I do remind them every week for 3 weeks, and then that's it. So, but it's a good way for the nurses to see what they've been doing and to track our patients. And then that's pretty much our screening form. But like I've said, it's been revamped to help with the nurses to screen appropriately, but also to get it as easy as we can for them. So, yeah. You okay there?
Of course, just when I was going to talk, I had a little coughing fit. Sorry about that. So as you can see what Sarah went over here with their form, really takes that algorithm that I showed at the beginning and puts it into question format. Sorry about that. So that assessment can be done to determine whether or not the patient is at increased or high risk for colorectal cancer, and gives those stopping points so that the staff know not to hand out the IFOBT. So again, just wanted to demonstrate this for all of you as a tool that you could possibly use to make sure that assessment is being done for each patient. And Dr. Tingley, just a question for you in regard to number 5, with patients that are presenting with symptoms, say blood in their stool, cramping, changes in their bowel habits, things like that. Could you just speak to how you might handle that conversation and whether or not you would use a digital rectal exam at that time for screening for a patient presenting with those symptoms?
Yeah, I mean, I think anytime somebody comes in talking about having blood per rectum, you should be doing a rectal exam at that time. There's lots of other reasons why people may be bleeding, and the more common one, just the hemorrhoids or the fissures, and that's something that you can visualize on exam. And so, yes, there should be, an anal exam done, and if you're down there, you might as well do the DRE, because we have the cards in the room so that you can actually confirm that there is blood right there. A lot of times what I'll do, again, because patients don't have insurance, it seems like, well, something's going on, you're having a really tough time with your GI system, I would like for you to see a GI provider. But if they don't have the means to do that, what I would do then is just do that enhanced physical exam, and then I would just do some additional blood work. So check some labs, making sure that there's not something infectious going on, talking about family history, things like IBS or IBD Crohn's, ulcerative colitis, those will tend to run in families. So if you get the sense that, okay, this person's at high risk for one of these things, you just want to get a good baseline hemoglobin so that's something that you can track. And then we start working our resources to try and get them in with GI. But yeah, I do think, this isn't somebody that you should give a kit to, because like Sarah said, it's going to come back positive. And then you're going to need the colonoscopy anyway. So, my preferred method is a lot of times I take the more conservative approach, because most of our patients just don't have the means to go right to a specialist. That is just not the reality that we live in. And so I will, if they've lost weight, okay, that's going to ring a lot of alarm bells. But if this just started, I'm going to say, let's get some baseline labs. Let me do the physical exam, and then I will have them come back in a month, and I would recheck labs, see how their symptoms are. If things are persisting, if they've now been losing some weight, that's when I say, okay, we're kind of at an impasse here, and I really need that assistance from a GI provider, and I need you to have the colonoscopy. And for the most part, patients will understand, but it is scary for them to kind of commit to going to see a specialist that they don't have the money to pay for. And thankfully, the hospital systems here are pretty good about assistance. They've got good foundations. So every patient is a different challenge, and I think you just have to, we're very lucky here at Falls because we've got nurse case managers who are here in the room with us. We've got social workers. We've got very dedicated nurses. Like we can find ways to get people the assistance if we just work together. But yeah, I think that's my one kind of trick on that is there may not be colon cancer that's causing this. I mean, there's probably something else going on. So you gotta look, and a lot of times I just monitor. So that's how I would approach that.
Thank you. And then just one last slide to share. And again, this is just another form of the assessment. This was developed by a health plan that was actually doing screening in the community, not paper screening essentially with this test, and then handing out fits to those who were asymptomatic and average risk. So as you can see, it asks similar questions to the form that Falls uses, but again, was focused on that fit distribution activity that they were doing in the community. So again, just a couple of examples of how you might convert that algorithm into an assessment that you use with your patients. Some EMRs may have these questions built into them, or it may be a request that you've made to have those questions built into your EMR, but these are some other examples for you. At this time, we'll open it up for questions, unless Sarah or Dr. Tingley, you have anything to add?
I don't think so.
Okay. Any questions for the staff at Falls or myself?
Yeah, I have a question, Brooke.
Yeah, go ahead, Mark.
So when you're using your screening tool and you've gotten them to accept an IFOB and they've taken it home and they didn't return it, and you followed up at 1 week, then you followed up at 2 weeks, then you followed up at 3 weeks. At that point, I understand what I'm hearing. Okay, you let it go. Then do you somehow mark your chart and start it again a year from then, or do you have something other time frame that you use?
Yeah, we actually just switched over our health system, or our EMR. So we actually are able to kind of mark the chart. In the top corner, there's a little yellow post-it, I'd say, and I put CRC screening. So that is put on every patient that doesn't have, or they're not up to date. And then one thing we've been trying to use or to utilize is the appointment times. There's a part in there that says why they're coming in. So I am able to mark that CRC screening. So the provider and the nurse actually have to physically take that out of their chart. So yes, we are scanning their charts quite frequently, and they are still being screened. And we've had patients be screened in January, the screening form, I've done 3 reminders, and then they're screened again in March. And so they're continually being monitored and watched, yeah.
And the other thing that we do when the kit is handed to the patient, an order is placed in the chart, but it's deferred. Mm-hmm. And so as a provider, when that patient comes back in 3 months or 6 months, we're always looking for any deferred labs that they might be due for. And so we would see that there was an IFOBT sitting there as a deferred lab. So then that's another chance to, hey, looks like we gave you a kit the last time you were here. It hasn't been returned. Do you still have it? A lot of times it's like, no, I lost it. And we give them another one sometimes. So, but that would be another place for the provider. Well, anybody can see it, but so multiple places to see that. But yeah, those sticky notes is what I think we're all kind of looking for now.
Okay, thank you.
Yeah.
And Mark, just for your information, Falls does use the same EMR that Horizon does.
I was beginning to figure that out.
Yeah. A couple other things that clinics have tried to get that kit returned to is putting an actual post-it note on it and say return by, with a date. Sometimes that helps. And then recommending that they put it in the bathroom when they get home so that they're not, in the bathroom and, oh, that's right, that kit's laying on the kitchen table where I left it when I came home. Having it in the bathroom where they actually need to use it is another tip that clinics have used. Other questions? Okay. Well, looks like we might wrap up a little bit early then, and that's absolutely fine. So just a couple reminders. I will follow up again with an email with that link fixed in the slides so that you can access those algorithms. And I will attach separate documents for those resources that we shared. We will send out an evaluation link with that, real short, 6 simple questions, should just take 2 minutes to complete. Included in that evaluation are questions or topics that you might want to see addressed in future learning collaborative sessions. And then again, I will send out information that comes forth in regard to the new screening recommendations, and also just plan for the August learning session to focus on that decrease in the screening age. It's going to be quite the change for health systems to address. We've all been working really, really hard just to get that 50 to 75 age group screened. And now if we drop it 5 years, that's adding a significant patient population to who needs to be screened. Of course, it's going to take some time for quality measures to catch up to that. The quality measures are written right now for 50 to 75. So that's going to take a while to make that change. And health plans typically have a year before they're required to cover any changes that the USPSTF puts out there. So, just know that will be gradual, likely in terms of the health plans covering that. So it might take some time to figure out which health plans have started and which ones are still working on that. So just a few things to consider as you're making plans for that change in the screening recommendations. Thank you, Sarah and Dr. Tingley, for your time today. Mark, do you have another question?
No, just wanted to thank the folks at Falls Community Health for sharing what works, and hope you won't mind if we copy some of it.
$5, no problem.
Yes. Thanks, everyone. It's great to see you all. Bye-bye.
Bye.